The primary clinical emergency of angina pectoris comes down to a strict energy debt. When the working heart muscle demands more oxygen than its compromised vascular network can supply, the tissue begins to starve. To resolve this ischemic deficit, pharmacology takes one of two distinct routes. We can either use hemodynamic regulators to fix the structural plumbing of the cardiovascular system, or we can deploy cellular stabilizers to alter the actual fuel the heart consumes. This diagram maps the myocardial balance between oxygen supply and demand. On the supply side, the objective is increasing delivery through targeted coronary vasodilation. Conversely, the demand side requires lowering mechanical workload by reducing heart rate, contractility, and venous return. These interventions are necessary because the vessel lumen diameter has been compromised, typically driven by a combination of physical plaque buildup and inappropriate vasoconstriction triggered by endothelial damage. Before any cellular intervention can succeed, clinicians must first manipulate the systemic pressure and flow of this cardiovascular pump. The foundational therapy for rapid relief across stable, unstable, and variant angina is the administration of organic nitrates. These agents vary wildly in their physical properties. Isosorbide mononitrate is a stable solid at room temperature, while amyl nitrate exists in an extremely volatile state. Regardless of the formulation, their primary hemodynamic effect is powerful venodilation. By relaxing the veins, they reduce the volume of blood returning to the heart, significantly dropping preload and cutting myocardial oxygen consumption. This biochemical flowchart shows exactly how that vascular relaxation is achieved. Once organic nitrates enter the smooth muscle cells, they undergo an intracellular conversion into active nitric oxide. This nitric oxide triggers a specific cascade. It activates guanylate cyclase, an enzyme that immediately begins converting GTP into cyclic guanosine monophosphate, or cGMP. Elevated cGMP drives the final mechanical step. It forces the dephosphorylation of the myosin light chain, physically preventing the muscle fibers from contracting and resulting in systemic vascular relaxation. Because this pathway relies heavily on cGMP, combining nitrates with PDE5 inhibitors is highly dangerous. Blocking the breakdown of cGMP leads to amplified, prolonged vasodilation and a severe, life-threatening drop in blood pressure. Looking at this administration graphic, we see another strict limitation. Constant exposure causes blood vessels to desensitize to nitrates. To restore efficacy, patients require a mandatory 10 to 12-hour daily nitrate-free interval. Nitrates provide potent, immediate structural relief, but their utility is tightly constrained by the body's rapid tolerance and the severe risk of drug-to-drug interactions. To manage effort-induced angina over the long term, beta blockers serve as the preferred pharmacological tool. Instead of primarily dilating vessels, they target the heart directly, reducing the frequency and severity of attacks by actively lowering both the heart rate and the force of myocardial contractility. Calcium channel blockers, or CCBs, offer an alternative mechanism. These act as arteriolar vasodilators, decreasing smooth muscle tone and lowering the vascular resistance the heart must pump against. This chart categorizes CCBs by tissue affinity. Non-dihydropyridines like verapamil target myocardial tissue, while dihydropyridines like amlodipine exhibit high selectivity for peripheral vascular smooth muscle. Diltiazem sits precisely between the two, balancing effects on both cardiac function and vascular tone. All of these systemic regulators effectively balance the oxygen equation, but their clinical application is entirely dependent on the patient's existing hemodynamics. This clinical matrix reveals the reality of prescribing antianginal therapy. When a patient presents with significant comorbidities, standard first-line options often become unusable. This diagram of the pulmonary system illustrates a primary constraint. In patients with asthma or COPD, beta blockers are strictly contraindicated due to the severe risk of inhibiting beta-2 receptors in the lungs. Even cardioselective beta blockers lose their selectivity at high dosages, meaning they can still trigger dangerous bronchospasms in susceptible individuals. Returning to our hemodynamic selection chart, blood pressure creates a dividing line. A patient with high blood pressure and heart rate is ideal for beta blockers, but if a patient has a high heart rate with stable blood pressure, a specialized drug like Ibavradine is required. Similarly, in patients suffering from heart failure, non-DHP calcium channel blockers like verapamil are entirely avoided because their negative inotropic effects weaken an already failing ventricular contraction. When standard pressure and flow adjustments threaten a patient's breathing or cardiac output, clinicians must pivot to highly targeted agents that avoid impacting blood pressure or bronchial tone. This infographic details precision alternatives. On the right, Nicorandil is a dual-action vasodilator, reducing preload via nitric oxide and afterload by opening potassium channels. On the left, Ibavradine functions as a selective pacemaker inhibitor, targeting the funny current within the cardiac sinus node. By decreasing diastolic depolarization in the sinus node, Ibavradine successfully slows the heart rate without negatively impacting myocardial contractility, ventricular repolarization, or systemic blood pressure. While it avoids hemodynamic collapse, it carries a unique side effect. Because it blocks the funny current, patients frequently experience visual disturbances, even though the drug has low permeability across the blood-brain barrier. Both Nicorandil and Ibavradine allow a clinician to precisely isolate and pull specific hemodynamic levers without setting off the systemic side effects associated with older classes of drugs. When patients remain inadequately controlled by all standard hemodynamics and precision agents, the protocol shifts to Ranolazine. Indicated exclusively for chronic angina, it is strictly prohibited for treating acute attacks. Ranolazine abandons the hemodynamic approach entirely. Instead, it operates on an ionic level as a sodium channel blocker, specifically inhibiting the late phase of the sodium current in the heart muscle. By blocking this late sodium current, the drug prevents an intracellular overload of sodium, which in turn prevents an overload of intracellular calcium. This stabilization drastically improves the heart's diastolic function and mechanical efficiency. However, adjusting cellular ion levels carries distinct risks, specifically palpitations and the prolongation of the QT interval, which can predispose the patient to further electrical dysfunction. Ranolazine dictates a clear transition in treatment, moving away from manipulating the pump and pipes and focusing entirely on managing the internal ionic stability of the ischemic cell. The final tier of antianginal treatment is Trimetazidine, a drug that bypasses systemic hemodynamics to change how the heart burns its fuel. This clinical excerpt outlines the specific metabolic shift. Trimetazidine inhibits the 3-cat enzyme, successfully blocking the oxygen-intensive beta-oxidation of fatty acids. This forces the cells to prioritize oxygen-sparing glucose oxidation instead. This metabolic reprogramming maximizes ATP production while simultaneously reducing intracellular acidosis and preserving mitochondrial integrity during periods of severe hypoxic stress. Because its pharmacological structure is similar to neuroleptics, this metabolic advantage requires strict clinical caution, particularly regarding the risk of drug-induced Parkinsonism in vulnerable patients. The treatment of angina reveals a clear pharmacological progression. Clinicians start with blunt systemic vasodilation, advance to highly selective nodal inhibition, and ultimately arrive at the targeted metabolic reprogramming of the ischemic heart, balancing the oxygen deficit from the inside out.